Thank you, Jean, for the nice introduction. So, ladies and gentlemen, dear colleagues, the topic I'm talking about is a disease that many of us give all their best in their clinical practice, but always run into problems. We have recurrences. We face a collective of patients that is young. It's a special attitude towards life. We call it the type A personality. And at least in my hands, up to recent time, we didn't have like a pure good treatment for this disease. A disease that is understood to have an acute type and a chronic type, and that the chronic type with high recurrences could also ultimately lead to a choroidal neovascularization. We discriminate focal to multifocal types, and just looking at the epidemiologic numbers, about 40% of all cases develop into bilateral types. The nice thing about CSC, and that is nothing new of you, is that up to 75% heal spontaneously. But we shouldn't forget that whenever we get fluid, especially breaking through the outer retinal barrier, the RPE, photoreceptors are a danger and visual acuity might decrease over time. None of us know what the reason for CSC is. We know, however, from ICG that there is some choroidal hyperperfusion, but we also know that the RPE plays not only a decisive role in the visual acuity, as explained, that it's the last barrier, the last frontier, but there were previous theoretical thoughts that the RPE might be the cause. Nowadays we have to say that it's more the choroid than the RPE, but still looking at these pictures, if you have these bubbles here of fluid, these bubbles here over the RPE, you better rush fast in order not to risk visual acuity. And the patients actually always come when they encounter the scotoma, metamorphopsia, micropsia, and the standard of care, at least in Germany, where this data derived from, is to wait. We put most of the patients on Diamox and Trusopt, but also for this treatment there is no rationale. I know from more the textbooks than from the clinical application in our hospital that conventional Subthreshold laser is applied for leakages that range outside the posterior pole. We would not treat it in that way. What I'm going to introduce to you is a clinical trial we conducted in Frankfurt, and we looked into VEGF inhibition in CSC. So we put our patients on Avastin because there have been some reports that anti-VEGF agents might lead to a decrease in fluid. As you can see here, that's 2008, that's 2009, 2011. All of these studies had controversial outcomes in the application of Avastin in CSC. There's one small case series of ranibizumab in CSC, but also their outcome was not convincing. In fact, there's one productive group out of South Korea by Lim and colleagues, and they looked into the VEGF levels of these patients, and they could not detect any change over time in CSC patients of these VEGF levels. So the whole rationale to treat the disease with VEGF inhibition remains unclear, and we looked into that. I just briefly want to touch that slide. That comes back to the hot laser in CSC. So the aim, right, is to destruct basically the leaking vessel, and the all theory was that then healthy RPE might migrate into that region. But the reality looked pretty much the opposite, right? The Photoreceptors have to undergo a thermal damage, so there won't be any light transduction in that area. So we're facing absolute scotoma. And also CNV has been described to develop out of this scar. So when we talk about a laser, just in theory and just briefly, we all know that we apply energy over a predetermined time. And by doing so, this energy needs to be absorbed by any tissue, right? And it can only be absorbed by melanin, by cells that contain melanin. So most of the energy, and this depends on the wavelength you use, the time you define the energy, but most of the energy is absorbed by the RPE, and the rest will go as a heat damage around that region. The idea about a micropulse is that for the exposition time, you also can define with micropulse at any of your conveniences. The exposition time is cut into many strains. That's why the term micropulse. But it's not only that. By looking at each of these strains, I'm sorry it's not really showing, but this is a magnification of each of the strains. You can define a so-called duty cycle to tell, okay, how much of this specific time is the on and how much of this time is the off impulse of your energy. And by doing so, you can raise the whole energy that you would apply. Why is that? Because the exposition time is so short that you would not, that is the temperature here on the y-axis, that's the time. So the heat damage cannot come up to what this is like the damage graphic border. And this is very appealing in diseases like CSC that take place at the posterior pole, because that's what you want to omit, right? You want to omit thermal damage. And Flexel and co-workers were looking into some of the pathophysiologic changes, and they described a metalloprotein as upregulation, which needs to be determined if that is good or bad. But what this paper tells us, that this micropulsed time is creating some sort of biologic change in a tissue. And it needs to be found out if that is in favor or not in favor of a specific setting. But we wanted to compare, and what we created was a trial prospectively over 10 months, which compared a cohort of Avastin treated patients to micropulse treated patients. We looked at visual acuity as the primary outcome, but we also asked them for changes in their metamorphopsia. We looked in OCT angiographic changes, and we also did macular field, visual field testing. We published this, I think, last year in Eye. You see here from the epidemiologics, we had 16 patients in the micropulse group, 10 patients in the Avastin group, and 26 patients that were in our control group that at that time received Truzopt or Diamox. If the patient was introduced in group 1 or 2 was not our decision. This is very important for us because we wanted to contribute to also the physiologic or psychologic component of this disease. We said that it's a type A personality. You don't want to push them into something that they don't really want in that disease. So what we did is we called it the real-life randomization. We said, listen folks, we got some nice laser here, we got some nice data of a drug, it should work, but we also know you got a high chance that it might resorb. Oh, by the way, these are all patients with a chronic CSC with fluid longer than 3 months. So we said, okay, now we want to act, and we give you the chance which treatment you want. We felt most comfortable with that. Just 2 or 3 epidemiological facts. About up to 50% were smokers, and only the minority of them had previous steroid use. This is because hypercortisolism is associated with CSC in first place. And these are the facts about the MicroPulse group, the treatment group. So, as a matter of fact, all of the 16 eyes were treated at baseline. 6 out of these 16 were retreated in follow-up, and 1 patient received a second treatment, so received all in all 3 treatments. What we applied was a 15% duty cycle, and the titration of the energy was made in a fashion that we used a continuous Subthreshold laser outside the posterior pole to assess the minimal thermal reaction. Let's say this was 500 microwatt, and we identified, okay, this person needs 500 microwatt in the periphery to achieve some sort of tissue reaction, like grayish reaction. We then doubled that and went to 1000 and put the MicroPulse setting. That is how we applied it. By this technique, these patients ended in the mean about 1,307 microwatt. Just let this number sink. 1,300, if you would apply that with a continuous laser, there is burned soil, right? You can see probably 1 week later the sclera. So we used this energy with a MicroPulse 15% duty cycle in our CSC patients. And what shows you here is that I was not hesitant to retreat very shortly when I saw that there is still ongoing leakage. Oh, by the way, what we treated was the leakage site in the FA. We didn't do ICG, we didn't treat like choroidal hyperperfusion. What we treated was the leakage site of the RPE. And when it comes to outcome, I first want to show you the leakage activity over time. So what you can see here is in the first row the MicroPulse group, in the second row the Avastin group, and then the control group. So just looking at this collective of patients that received Trusopt and Diamox, 92% of these were still leaking after 10 months of observation, whereas in Avastin, about 60% had still leakage in the FA. Only 12% of the MicroPulse patients that we kept on treating, oh, by the way, also the Avastin people received shots over time if there was not a stop in leakage, dropped to 12%. And we liked it really much. But now how does that translate into visual acuity and in subjective well feeling? And this is something where we have to bear in mind that this is a collective of chronic patients. So in fact, visual acuity is compromised over the whole time. If there is fluid, photoreceptors are not acknowledging that. But the MicroPulse group gained about 6 letters over time. The spherical equivalent, which we used also because we wanted to know how refraction changes, also improved. Whereas in the bevacizumab group, we all actually lost 1 letter, and in the control group, we lost about 2 letters. So in this study, only the MicroPulse allowed for visual acuity gain. But did this also translate in a better subjective feeling of our patients? The so-called life balance? So, I have to say. So I think the guiding of CSC patients in including and into persuading what is happening is the key to the whole disease. So what we did is we explained to them thoroughly what the problem is, that we have fluid in a compartment where we don't want to have it, and then we showed them, okay, there is no fluid later on. but most of the patients still had metamorphopsia, right? You can't just heal the disease with MicroPulse. You can help to get it in the normal state. But I have to really make the point, that's not a treatment for CSC, it'll help the disease. And we looked into macular field visual defects, and this also translated into improvements. So the mean deficit in the central macular field improved, whereas in the bevacizumab it also improved, but it did not translate into more happier patients than in the MicroPulse group. Just briefly, we know from recent work, especially from Rick Spade, that the underlying cause of CSC is the choroid, the hyperperfusion. And when you look at CSC patients, you face a much thicker choroid than in non-CSC patients. So I know that in the States, PDT is like maybe standard of care. But when I talk to US colleagues, they also say, well, everyone does it differently. PDT, as we know, is the application of verteporfin to the systemic circulation, which then gets activated and will lead to a localized thromboembolic event. And we know from the old AMD data that, okay, you can stop choroidal perfusion at that area, but we also know that this atrophy is going on over time after you are not treating with PDT anymore. We also know that the choroid is there for a good reason. We need it for our nutrition for the RPE. So there won't be any perfusion later on. So the question in CSC treatment is, you can't apply PDT like you would treat your old AMD patients. You have to some sort play with the parameters. So you either apply half of the dosage or you reduce the exposition time, cut it down to half. So that's where low fluence PDT comes into play. That's just what I pointed. PDT in CSC, patients that are young, that actually have a good visual acuity, I would be hesitant if I just, use the old parameters and just, try to get less choroidal perfusion. And this is not old knowledge. This has been reported on and on. So what we did, and this study has not been published yet, we looked after we did the Avastin MicroPulse comparison, we looked into how would prospectively look our patients, not the same collective of patients, but also chronic patients, look in a head-to-head trial. And we could include 10 patients in the MicroPulse group, 12 in the PDT group, and we had a control group. And it was the same sort of randomization. We said, okay, listen guys, we have these two. We have a very good rationale to believe in MicroPulse. It was superior to Avastin. That's why let's go to the PDT. And as a matter of fact, we also looked in visual acuity, but we also looked in things like contrast vision and into autofluorescence. And these are brand new data and are just submitted for publication. We looked into 16 weeks, so we wanted to have a short response time rather than the 10 months. And here are the results. And the results tell you, left is the MicroPulse group, in the middle is we used half of the dose of PDT, and on the right side it's a control group, that both MicroPulse and PDT led to a drop over 16 weeks. Okay? So both worked, whereas the control group did not work. We saw that there was a gain in visual acuity, which was both significant in both groups. And we saw a more reduction in central thickness in the PDT group than in the MicroPulse group. But I conclude here because there it comes to the discussion which CSC patient you would use for a PDT and which you would rather feel comfortable with a MicroPulse group, because this is what we found in our latest trial. Thank you for your attention.